that you did it versus like doing a peak flow and then the next visit do a peak flow and then next visit do a peak flow, you know what I'm saying? Or did they have like a 5-day diary or 7-day diary, and like was the
No, this is when I get a child that comes in, I always do, you never know. There's some 7-year-olds that can do spirometry testing really well, and then there's some 7-year-olds that absolutely can't. So no matter what, I do a peak flow, the best out of 3, and educate them on how to use it and how to, you're recognizing your triggers at home and when you would want to use it at home. Then I'll attempt the spirometry test. She did a really good job. She had great effort on both, both peak flow and the spirometry testing. The curves were appropriate, and you can tell her effort was good. And then I'll always, give a bronchodilator, wait 15 minutes, repeat the peak flow meter, take the best out of 3, make sure that their, effort is good, and that they're holding their peak flow meter and they're not blocking the back part where all the, the air would come through, and just really trying to get them to understand that and how to use it at home, and then repeat the spirometry test as well.
Right.
So it wasn't like a 5-day diary. It's me teaching them for the first time how to use a peak flow meter.
So Johnny, go ahead.
I was just thinking, like, is this a consistency, and if it's a consistency, then that would trigger like what's going on here, like really like what's going on here. Are you really having that big of a change every time, or, you know what I'm saying?
Yeah, definitely understand what you're saying. And that would, that's something that you educate them on, especially if they're about to see their provider or just to keep a diary at home.
So Johnny, this is a point. This is a one-time point in time set of peak before and after peak flows that Lisa did. So Lisa, in a way, did pulmonary function tests with 2 instruments, a highly sophisticated PFT machine and a peak flow meter. And she, just like when a patient brings in their blood pressure cuff and we check to see, are they getting the same numbers on their blood pressure cuff that we're getting? What she was doing was checking to compare, are the peak flows on that peak flow meter, how do they compare to the sophisticated full PFT she did today? So I would ask somebody to get out their calculator, because on the PFT, we have a peak flow, but it's in liters per second instead of liters per minute. So if you look at those PFT peak flows, could somebody please multiply 5.35 times 60 and tell us what you get?
$321.
All right, so on Lisa's PFT on the machine, we got a peak flow. If you convert liters per second to liters per minute, so it's comparable to the patient's peak flow meter, we got a peak flow of 320 compared to 170. And most likely that 5.82 is going to give you something close to 400. When you get it, just yell it out. So let's say 390 or 380 compared to 290. And that's our question for you all. That seems like a very big measurement discrepancy. And we wanted to ask what people thought about that. What's 5.82 times 60? If it were 6 times 60, it would be 360. So it's maybe something like 350. What is it, Elizabeth? You're shaking your head. But you're muted.
It's 349.2.
Okay, so that's our question. What do we make of such a big discrepancy in our? Is that just a random thing? And that's our question for the group. That about the difference in measurements there, and also to remind people that on a regular PFT, you have to multiply the number by 60 to get a peak flow that compares to a peak flow meter number.
So Dan, was
Comment.
that her peak flow meter or yours?
Lisa,
It's ours that we gave to her.
so you got one out of the box,
Brand new.
gave it to her and show her, so brand new.
Sounds like you need to buy a new brand.
Okay.
I was wondering, was the mouthpiece round on the peak flow meter that came out of the box? Versus
Yes.
like a more oblong mouthpiece that goes on the PFT machine?
You know, and I know that some places don't use their mouthpieces on the peak flow machine, and I do.
Yeah.
And I'll make a kid. I mean, unless they
Right.
can't put their mouth.
Well, I
over
just
it.
know that like it's
Yeah.
hard to keep your mouth completely sealed around a
Mhm.
round mouthpiece that's completely round.
I
Did you
think
think
the-
she leaked any?
No, I mean, that was the thing, was her effort was really consistent. She was you know, a good child patient, and you could tell. I mean, really the only thing that she would do that I had to correct her on was, you know, be careful where your hands are.
Mhm.
Don't make sure that it's not back behind. And so we would always, we wouldn't use that one, but it seemed really consistent. You know, you can, after years and years of doing this, you can see inconsistent effort, and you can see consistent effort. and
Dr.
good effort.
Sangani has a couple comments. Do you want to speak them out, Dr. Sangani? If not, Mitra can read them for us.
Yeah, absolutely. So I usually don't see pediatric patients. That's why, and for my adult asthma patients, I have relied more on the PFT measures and clinical symptoms solely. For the monitoring perspective, I rely on some of the questionnaires like asthma control test and other things, rather than just one number peak flow. And also to some extent, I have not personally spent time coaching the patients how to use peak flow. So I sometimes wonder that the number they report to me, how reliable that could be. Again, it is still a part of the GINA guidelines and stuff. So you won't be wrong if you advise patients to use it and they guide their therapy that way. But that's my 2 cents, that I have kind of moved away from using peak flow meter readings only. And also, as you pointed out earlier, that it's a single point value. So I would not put too much emphasis on this. Even the same individual can have variations, can be done on 2 peak flow readings in the morning and the evening. So it can be that variable. But the important fact is, appears that way, that if patient is improving post bronchodilator, that's a more important clue in my mind for treatment and what next step for the treatment would be.
So I have a question for Lisa. So when you looked at the spirometry curves, was it good quality spirometry? I mean, did you have, repeatable and the shapes of the curves look good and that kind of stuff?
Yes, absolutely. Or else I don't think we would be here presenting this case. I think it was just pretty bizarre that, you had a really good pulmonary function testing and really good effort on this child's part, in both testing, peak
So in
flow
this
and
case-
spirometry.
Yeah, so I'm going to agree with Rahul, because with spirometry, you have the ability to assess the quality of the test. You have repeatability, you have the shapes of the curves, you have, and so I'm going to believe the peak flow that you got from the spirometry more than the peak flow that you got from the meter. And I guess I'm going to double down, and I'm going to say there's probably something wrong with that peak flow meter.
So which test was offered the first? What values were the first measured, and what comes after? Was the PFT first, or the peak flow readings were the first?
Peak flow first.
I see. Yeah, so I
think it's-
believe that's what probably we are seeing, that over time, you got patients teaching about how to use peak flow. At the same time, she underwent the efforts to do PFT. So over time, there is a learning curve, right? In the PFT, that's all talked about all the time. So I think that's the reflection we are seeing, that if you look at the PFT, peak expiratory flows, which Dr. Doyle asked us to convert into the minutes, those values are consistent. They are in a 320, 340 range. So that, I believe that's probably the true baseline of the patient. Was it a post bronchodilator? Those PEF, both of those PEF were post bronchodilators?
Pre and post.
Oh, those are pre and post, I see.
Yeah.
So probably maybe beginning of the test, she was somewhat obstructed while getting the peak flow done. And then she was offered albuterol. And then I'm just guessing the sequence of the events, how it would kind of have happened.
And I was able to find her, and I have her PFT pulled up in front of me if anyone, and I'm looking at the curves again. They look good. And I have all the data.
Okay.
If anyone wants it.
So if she's she being compliant to her treatment, and then if you repeat some of her measures on the PFT, I think you will see, and if it's a good quality PFT, you will see her baseline around 320, 340 range, I would say.
So,
If any variations lower than that, 25% or 20% lower than that, that's where you probably assume that her asthma control is not so optimal.
So I'm going to suggest a couple more lessons from this case. I mean, Dr. Weissman and Dr. Sangani have already pointed out some important lessons, and obvious. I just want to reiterate the one about a point in time measurement is a point in time measurement, and a series of measurements is much more important for lots of reasons in measurement and science in general. So watch out for point in time measurements. That's one thing. Another thing is that a measurement with a highly accurate instrument being used by a highly trained, experienced operator is much more reliable than a measurement by a simple instrument. And we have that experience measuring things all the time. And then I guess another thing is that watch out, you can get false positive or false negative measurements with home monitoring, whether it's a peak flow meter or a blood glucose monitor or a pulse oximeter or a blood pressure cuff. Home monitoring is really important, but you have to look at a series over time, and you have to be aware of the limitations of that kind of measurement. And then last but not least, guys, when you submit cases, use a screenshot of your spirometry so it's de-identified, and attach it to the case. The way the echo case submission system works is that it allows you to attach one file and one file only. Get a screenshot of your actual spirometry. Unfortunately, that cuts off the curves, as Dr. Weissman and Dr. Sangani just reminded us. Look at the curves. But get a screenshot and submit that then as an image, so we can bring it up when we're looking at cases like this.
Thank you so much, Dr. Doyle. That's a really great plug for the case submissions. And I do want to mention too, if you want to just email us those images, we're more than happy to save that and archive it on our end as well. And we'll just keep it associated with whatever case ID number that you submit it in. So just always shoot us an email. We're happy to help submit the case for you. Or I know the word case presentation can sound kind of daunting, but like Dr. Doyle mentioned, it can even just be like some labs and a question, so we're always here to help. Just let us know.
Oh, one other thing is, Mitra, is we have, I think 2 or 3 new people who joined us since we started in here. You can see who they are.
Yep, exactly. Thank you. So I think, Beth, I see you're waving. Thank you for joining. Did you want to do a little intro for the group? I think you are still muted. Oh, there we go.
My name's Beth Hudspeth, and I'm recently started at Camden Camden Clinic Family Practice in Summersville, and I work at Ansted 1 day a week as well. doing family practice, and so glad to still be here on the Project Echo cases and learning new things about spirometry. Appreciate it.
Thank you so much. We're so happy you can join us well. And Krista, I think you also joined a little bit afterwards, after the intros, if you wanted to say hi to the group or anything. No pressure at all. No worries. And Dr. Doyle, I think there was one more person.
Luann.
Luann, I think, yes, Luann, if you wanted to do a little intro as well.
Good morning. I'm Luann Jeffries. I'm the Breathing Center Assistant for the Grace Ann Dorney Pulmonary Rehab Center and Black Lung Clinic at Cabin Creek. And Krista Critchfield's our respiratory therapist there as well.
Awesome. Thank you so much. All right. Were there any other questions from the group about the case that Lisa and Dr. Doyle presented? Or maybe any comments? All right, and Dr. Doyle, Lisa, did you guys have any other questions about your case before we move to the didactic portion?
Nope. Thank you for the discussion, and I especially appreciate the WVU Hub member pulmonologists, Dr. Sangani and Dr. Weissman for helping us with this.
Absolutely. Thank you all so much for the great case and the great discussion we had here. All right, Dr. Sangani, I'll turn things over to you. I'm happy to pull up your didactic and advance your slides on my end, but if you'd rather do that, I can give you the capability as well.
How about you do this?
Okay, sure. All right. Can everyone see this okay?
Yes.
All right, I'll turn things to you now, Dr. Sangani. Thank you.
All right. So the topic of discussion today is slightly different than what we discussed with the case. And I apologize, I do not have included the case with my talk. I want to talk very specific about the utility of antifibrotics and how it's emerging, its role into dust-related progressive fibrotic lung diseases. Next slide, please. I do not have any relevant disclosure for the talk. Objectives would be, I would not like to introduce a little bit of complex classification system of what we call interstitial lung disease and point out some of the synergies in the injury process that happens in the lung, introduce some of the spectrum of what we call coal mine dust lung diseases, then describe the progressive massive fibrosis, then also describe the progressive fibrosing interstitial lung disease, and then hint towards the point that why antifibrotics has been becoming more popular in those categories, and spend some time on some molecular mechanisms, and lastly, our initiative with Dr. Weissman, me, and some of my colleagues, and the WVCTSI and BI, the pharmaceuticals that we are planning to initiate the clinical trial here. Next slide, please. So as you can see, it's a very complex disease, interstitial lung disease, or the better terminology for that is diffuse parenchymal lung disease, because it not only involves the interstitium of the lung, but also adjoining alveolar epithelium and capillary endothelium. But the two main themes of diagnostics appears to be if you know the etiology or if you don't know the etiology. And this is how I categorize this patient when I see them in my clinic. I start going down systematically, try to put patients into any one of these boxes, whether the patient have predominantly smoking associated interstitial lung diseases and characteristic imaging patterns, whether they have connective tissue disease associated ILDs, various drug associations, some of the exposure association, and that's where the coal dust, silica dust, hard metal, and asbestos dust comes in a picture. Whereas on the other side, on the right-hand side of the picture, the big category is etiology unknown, where there may be some risk factors and associations, but never proven yet causations about the etiology. And one of the big one in that group is IPF, as we know, idiopathic pulmonary fibrosis. Next slide, please. So this is the synergy that I want to point out. If you look at on the left side, the small picture, we know pretty well that cigarette smoke exposure can lead to emphysema. And there is a good amount of literature, kind of evidence supports that it also develops what we call fibrotic response in the lung. It yes still considered as a risk factor for IPF, but probably the causative event appears to be not, even though there are some true believer in that. But overall, what the point I want to make out that it's a one single risk factor leads to two different episodes in the or the injury process in the lung, and they all can simultaneously live together in the same lung. And on the right side, if you draw the roughly similar analogy, if other form of particle exposure, such as coal dust or silica dust, it can has a strong association with development of emphysema-like disorders. And also at the same time, we know very specific disorders like co-workers pneumoconiosis and progressive massive fibrosis. And matter of fact, they both can be living in the same host together. So we have some synergy of how the injury happens to the lung. Click next. And I think next. And that's where I think if we have a mechanistic synergy, then is there a possibility that there could be therapeutic synergy between the two different injury processes as well or not? Next. So we will keep coming back to these graphics. So let me first describe a coal mine dust induced lung diseases, the spectrum of it. Next. As we know, coal is still prevalent with the different frequencies in different part of the country. Next. So this is the terminology now we use to describe the spectrum of the disease that is caused by the inhalation of coal mine dust. And then it is a combination of pathological and radiologic findings to describe the clinical phenotypes. The most commonly we know is as CWP or coal workers pneumoconiosis. It has led to some confusion terminology because clinically we describe it only as interstitial disease caused by inhalation of coal mine dust, but legally it also involves the airway disease. Next slide. So this is the 6 major disease processes that falls into this umbrella. We know simple coal workers pneumoconiosis followed by complicated coal workers pneumoconiosis, or known as a progressive massive fibrosis. Next is a mixed dust pneumoconiosis where there is a coexisting silica exposure. Then chronic bronchitis and emphysema phenotypes. And then dust-related diffuse fibrosis, which oftentimes mimics greatly with IPF. Next. There will be some animation on this slide, Mitra. So when I say next, it will be only on the same slide. So if you look at this, this is a combination of things I want to describe here as what is the definition, what are the pathologically or radiographically. So starting with the left side, simple coal workers pneumoconiosis, disease process starts with a coal macule, which coalesces and becomes a coal nodule, but usually less than 1 centimeter in size opacities. That is on radiograph. Can you hit one? So this is the histopath, how it appears on the small, the pigmented cells you see, that's a macule, and there is adjoining emphysema. And then once some of those macules have coalesced, it started becoming coal nodule. Then comes the complicated coal workers pneumoconiosis or progressive massive fibrosis, when these nodules become even larger. And the diameter that is described on autopsy is more than 2 centimeter. Whereas on the radiograph, we call it more than 1 centimeter opacities when the smaller opacities have coalesced together, and we start calling them or identifying them as a PMF lesions. Hit next. So this is the rough example where all those things have coalesced together. You can start seeing a little bit more pinky stuff coming up. That's a fibrosis and some maybe necrosis within that. And also it has started giving a lot more architectural distortion. Then the last the point that I want to make out from this is a dust-related diffuse fibrosis, which is about 20% of minors at autopsy finding. And it may correlate with some of the irregular opacities seen on the x-rays. It has a somewhat lower lung predominant, just like IPF. That's why differential diagnosis becomes very critical for, at least for the clinicians who are interested in ILD. And hit next. And that's how it looks, that all those PMF lesions are there, but now there is a bridging fibrosis, much more solid fibrous brands and collagen depositions start seeing, and there is a lot more greater extent of architectural distortion. Hit next. So on a radiograph, we have small nodular opacities. I'm sorry for the poor quality. We may not be able to pinpoint that, and hit next. I just wanted to see the clinical progression on the same host, that how it has evolved in several years. And then on the right side, you see progressive massive fibrotic lesions, predominantly involving upper lobes, but also some areas of the lower lobe. Next line. Clinical features, as usual, it's how we see in patients. So everyone have a more or less non-specific symptoms, cough, dyspnea, sputum production in various frequencies. 35% of minor can have chronic bronchitis. So look for overlapping COPD features. If the disease progresses, they start developing a signs of cor pulmonale, like lower extremity pulmonary edema, or some signs and clinical exam findings of pulmonary hypertension. And the rest I will skip for the moving on for the topic and the brevity. Next. As I mentioned, 35% of the coal miners could have coexisting chronic bronchitis and emphysema, and symptoms can be of all those things combinations. But how it points out that there could be a larger early decline in FEV1 at the beginning of the work. And we know that it appears to be independent of the cigarette smoking effect. And eventually it can lead into bullous and pan-acinar emphysema, along with what is in core of the coal injury is the centri-acinar emphysema on the pathology. Next. The spirometry, this may be slightly relevant to what we discussed earlier in the case, that it's quite variable. If you can see, it can be normal in most instances, like anthracosis or some chronic bronchitis, some other rare complication of Kaplan syndrome, where they have comorbid rheumatoid arthritis. In a advanced disease like cold-workers pneumoconiosis with more on a complicated side, there will be probably restrictive physiology we start seeing. Obstructive or larger decline FEV1, as I mentioned, can hint towards a coexisting COPD. And if both are predominant diseases prevalent in the same host, then it can be mixed. So you can see that lung function pattern is not specific at all. It can be leading in either directions. Next. So I think there are several, you can hit next, wait, you may want to go back. I thought everything coming on the same together. This is, I wanted to point out, can you hit next, that this is like a smaller nodule opacity on the pathology. The first image we saw was a cold-workers pneumoconiosis, whereas on this one, it's a more of a silicotic, more fibrotic appearing nodules. On the radiograph, you sometimes see with those tiny errors, what we call pseudoplex, and there is a more coarser nodules compared to the more finer nodules that we saw on the earlier slide. Next. This is the one example I found on one of the article was about the mixed dust pneumoconiosis, where there's both exposure to coal dust and silica dust. And the silica dust likes to calcify, so you can see that calcified lymph node, and also giving a kind of mixed pattern of nodular, the finer nodular pattern on the axial cuts of the CT scan. Next. And this is, I think, the PMF lesion that I previously also showed in one of the, it's upper lobe predominant, and it's kind of a false positive PAT because it's an ongoing injury process, inflammation. Next. And I believe this is the diffuse dust-related fibrosis, or DDF. And you can see basilar disease, architectural distortion. To some extent looks like a honeycombing cyst, but what gives away from IPF is most likely all the calcification we see in the lymph node and probably occupational history. Next. So progressive massive fibrosis, let's put a little emphasis on what is progressive. So it's been known that many decades that it can be progressive even after patients and the workers have been removed from the ongoing coal dust exposure. And there is one data from one of our earlier provider at WVU, that study of a coal miners who progressed to massive fibrosis documented FEV1 decline of 81 ml per year and FVC of 74 ml per year, which is slightly accelerated when it has moved towards the progressive stage. And that's how we probably define them as why it's become disease have become more progressive. Next. As we know, partly from the epidemiological lessons, since early 2000, there is a rise in the cases of progressive massive fibrosis. And depending on the tenure of work, the higher amount of work, it's a higher rise in the prevalence. And you can see on the right side, the map distribution where they are located. We are right in the center of it, almost center of it. Somewhat more southern West Virginia and some Kentucky aspect are also involved heavily. Next. And this is a very astute article by Dr. Pat Song that I learned a lot from reading this article. It was back in 2012, 2013, that all the radiographic opacities, what are the new lessons is they are not always rounded. It can be irregular and lower lung zone dependent, which is pointing towards a diffuse dust fibrosis. And there was no meaningful differences in many of those variables, what we saw between rounded versus irregular opacities. However, the tobacco use data was limited. Next. So functional and radiographic abnormalities progress after exposure ceases, likely due to ongoing inflammatory effects of the retained mineral dust. And accelerated decline in FEV1 has been associated with work in a roof bolting, lack of respiratory protection, exposure to explosive blasting fumes, and use of a stored mine water for dust suppression sprays. These are some of the factors which has been linked to with a more accelerated decline in FEV1 seen in recent times. And also this rapidly progressive coal workers pneumoconiosis, there are, it appears to be, from my discussion, my understanding that based on some of the work pattern, how it has evolved in Appalachia, such as working in a smaller mine or mining the thin coal seams, or coal with a high carbon content or elevated respirable silica exposure have led to more rapid rise in prevalence of progressive massive fibrosis. Next. Again, coming back, so we described the first box, the blue box. Now let's describe the ILD next. So I want to focus, as I mentioned, next. So where we stand from the therapy in the IPF world, and these are the two main agents we have, nintedanib and ferfenidone. They have variable mechanisms. The nintedanib is more of a tyrosine kinase inhibitor, whereas the other side is not yet completely known, but combination of things. There are several large trials on both ends, almost identical effect seen on both agents by reduce slower decline in FVC by 50%. So about, in other words, we can say that it's a gain about 100 ml to 150 ml per year, depending on the underlying disease process. And the important signature were observed for nintedanib was time to first exacerbation was reduced, and there was some mortality benefit in a pre-pooled analysis for ferfenidone. Next. This is exactly I mentioned that at the end of a year, the disease modifying therapy showed some gain, means a slower decline in FVC by 50%. Next. There is an emerging entity we start within the ILD world, we start calling the progressive fibrosing ILD. So pulmonary fibrosis is associated with a number of specific forms of ILD. We saw that classification, but it can lead to progressive decline in lung function, poor quality of life, and ultimately the death. And it's about 1/3 of those patients can fall into this kind of specific category. Next. So if you look at the recent guidelines, how to manage ILD patient, this is just like a 30,000 feet bird view that you start your workup with a history, sometimes offer some invasive testing, start with, and then some do good multidisciplinary discussion with thoracic radiology, pathology, and probably get a help from an ILD specific clinic like us. and then offer a treatment. But if you focus on the red box, on the disease monitoring, there is a decline in FEV1, progressive changes on the scan, progressive symptoms, then you start calling those patients somewhat as a progressive fibrosing ILD. That's emerging entity. Next, please. And yes, as I mentioned, the disease behavior is the one that when we see this patient on a regular basis, we start focusing on the disease behavior. Next. Next, please. And this is from the same article that almost every different kind of ILDs has this progressive fibrosing ILD kind of a phenotype. And because every ILD itself is so complex and heterogeneous disease process, it takes time and effort to put patients into one of these circles. And then again, you have some subset of the patients from each different kind of underlying disease process are chronically progressive despite using standard of care therapies for them. Next, please. Next. And there has been some effort. There is no consensus definition out there what describes a progressive fibrosing ILD. I will not take too much time on this. This was just one position paper in a Lancet, but keep hitting next couple of times. I think there are a couple of boxes I want to point out. So essentially what they have looked into is looking at the FVC decline, looking at the DLCO decline, looking at the progressive changes on the HRCT. People can disagree, agree about the percent change, what you call progressive. And sometimes you just rely on a patient's symptoms. And there are some risk factors associated with in each disease process, what has become more progressive over the years. But this is what I use the combination of all this in my clinic to determine whether my patient is still progressive despite having them on a standard of care therapy. Next. Hit one more time. Oh, keep hitting. I think, so I'm just wanted to point out here, all the trials, which is looking into this direction using both agents that first they approved antifibrotics and started using in IPF only. And then they started expanding the indications and started looking into more progressive fibrosing phenotypes of different form of ILDs. Next. I have one slide if I'm describing the inbuilt result, which makes the basis for keep hitting 3 times. I think there are 3 animations. I'm sorry, I'm making slides with a lot of animation. That doesn't help with the Zoom talks. You may have to go back. I'm sorry. So the inbuilt trial was essentially designed to include different forms of ILD other than IPF. You can see the breakdown of different form of ILDs into that. Next, please. And what they found, they divide the patients, what they enrolled into 2 groups, the patients with underlying UIP pattern on the scan and without UIP pattern. And they both group showed a positive effect of nintedanib by decreasing the decline in the FVC. UIP group had a slightly higher response compared to non-UIP group. Next, please. This is exactly, it shows as how much was the difference they gained. Next, please. And this essentially made the basis for approving of nintedanib for this category by FDA. Now, hit next. And this is what I want to point out, that the red box, where once you monitor the disease behavior and determine the disease progression, and despite being on a standard of care therapies for all different diseases which falls into ILD category, there is an emerging role of now antifibrotics. And matter of fact, Inbuilt Trial, it's more widely adopted now for many practitioners who sees patients with ILD and then often consider these drugs. Next, please. Next. All right. Now, what we want to focus is there some correlation with the coal mine dust-induced lung disease and antifibrotic? Next. So this is a very complex pathophysiological process that goes for the lung fibrosis, where the first injury happens to alveolar epithelium, followed by epithelial fibrotic interactions and aberrant repair and fibrosis, which will lead to end-stage changes like honeycomb changes on the scan or a path. Hit next. And I want to point out, look at here, there is a mention about environmental particles initiating the injury process, along with many other things listed as a potential etiology like viruses, immunologies, drug-induced gastroesophageal reflux disease or gastric acid, those kind of things. Next, please. And specifically looking for respirable dust, which goes into lung, such as on the left cartoon, it focus on the silica injury process on macrophage, which eventually leads to cascade of events with fibroblast depositions and collagen comes in, and then end stage disease changes happens. On the right side, the figure points out the same kind of process with different inflammatory markers and reactive oxygen species, oxidative stress. But in the end result appears to be the same. Either you look at the just a generalistic approach for how the lung fibrosis evolve, or very specific to silica dust or coal mine dust. Next, please. And that's where Dr. Wiseman and eventually we got involved into this project, started thinking that is there a possibility that antifibrotics could have impact? Because when it goes down, initial injury process could be from a different agents, but downstream effects appears to be involving the same key players at the cellular level. Next line. And this was one animal-based study that I found, very astute observation by this group. Next, please. And one more. Hit one more, please. Yes. So from H to K, these are all the differences in the mice model they have for the silica injury, and it all has a better impact from using an nintedanib on these patients, not patients, these mice, with the markers of inflammation, granuloma formation, fibrosis, and so forth. Next. Now, quickly and briefly, I want to point out our initiative that we have already embarked on. It's IRB approved as of late last week. It is an initiative by WVU, our section, NIRS with Dr. Wiseman's guidance, and then BI, which is predominantly contributing towards the nintedanib as a pharmaceutical. We want to assess a double-blind, randomized, placebo-controlled trial evaluating efficacy and safety of nintedanib over 52 weeks in a patient with a progressive fibrosing coal mine dust-induced ILD. Next. Aim, we want to evaluate the efficacy and safety of nintedanib in this very specific patient group, and how we want to define it as that if patient has PMF on HRCT, progressive massive fibrosis, please call us back, because that way we can help and try to see. And the other category, we want to define progressive if they have a smaller opacity, but decline of FVC more than 5% predicted in the last 12 to 24 months. And then the DLCO should be between the range of 30 to 80%, and FVC should be more than 45%. Next. We want to give this drug 150 milligram twice a day versus placebo, 1-to-1 assignment in each arm. And the projected power analysis suggested we want to recruit about 160 patient total. The study duration is 52 weeks. Next. Key exclusion criteria, obviously we want to exclude patients who does not have any progression of the disease documented, or they continue to work. And there are some various list of exclusion criteria. So I would not, with the concern of time, I would not go too much detail into that. I can make those available to the group if they are interested, the key points of the trial. Next, please. And this is the primary endpoint we want to evaluate. What is the change in the annual rate of decline in FVC? And then there are several secondary endpoints we want to evaluate as well. And also we want to confirm the safety outcomes of the adverse reactions. One thing I point out that it is loosely following the pattern what the Inbuilt Trial evaluated, but Inbuilt Trial specifically ruled out patients who had a coal mine dust exposure. So the impact of nintedanib is not clear in this disease population, and I think the clinical practice is quite variable. Next, please. This is a primary contact. If you see, I'm glad to see that a couple of folks from the working at the Black Lung Clinic are here. This is a perfect opportunity for me to introduce this trial, and I want to gain your attention. Please call me or Erica, who is my primary study coordinator, or anyone at CTSI. We will try to find you the right channel. We really want to help out our patients. And I believe this will be something as an important therapeutics in the care of this patient. As of now, it appears to be only supportive care and some preventative measures, but nothing as a therapeutics in this disease specific group. Thank you. I think this is my, or maybe there's one more slide. Okay. This is the place I work and live, and this is my small family. I would happily take any questions if the group has.
Thank you so much, Dr. Sangani. That was the best way to end the didactic, was with that photo. So beautiful. I love that. Thank you. Before we end the session, we have about 3 minutes left. Did anyone have any questions, comments? And as usual, we'll be attaching the slides in the recap email. So Dr. Sangani, your contact will be there for everyone. I just want to also mention Elizabeth and I are housed within the CTSI Project Echo is. So if you need to reach the CTSI, you can also contact us. But any questions or comments from the group? And if there are, like I mentioned, please feel free to email us or email Dr. Sangani. Tammy, I noticed you unmuted. Was there something you wanted to comment on or ask? Oh, no worries. All
What
right.
was folks from Black Lung Clinic? Can you remind me the name?
Everyone from Black Lung Clinic, if you guys can maybe use the raise hand feature, I can read it off. I don't want to mistakenly say some names here. Luann Jeffries, thank you. Johnny Mullins and Sheila Morgan, awesome, thank you.
So very nice meeting you both, and my cell number I listed on the talk. So feel free to give me a call if something that you would see as a potential patient or who can benefit from our initiative here. Thank you very much.
And Dr. Doyle, I noticed you raised your hand. Do you have a question you wanted to ask the group?
Well, one comment, we've tried to identify talks that we want to give annually at this CLD Echo, and I really think this should be, put it on your annual list, because the first half was a really great review of radiologic and histopathologic correlations in the progression of coworkers pneumoconiosis or coal mine dust lung disease. And it's so interesting. So thank you very much for that. And then a quick question, would this be considered in the FDA categories, a phase 3 or phase 4 clinical trial? Where does it fit, Dr. Sangani?
I believe is a phase 3. Dr. Wiseman, if you're still here, you can correct me if I'm wrong.
So I would say it's phase 4. And the reason for that
Okay.
the reason for that is nintedanib is approved for progressive fibrosing ILD. The studies that were done, the Inbuilt study that Rahul presented included folks that had occupational exposures, but very few. So even though from an FDA standpoint, it would be okay to prescribe nintedanib for somebody with progressive CWP, it really hasn't been studied at all. So it would fall under phase 4 since it's not going for a new indication.
Thank you. That's it.
Alrighty, well, thank you all so much. Thank you again, Dr. Doyle, Lisa, for the case, and Dr. Sangani for the awesome didactic. We'll be sure to have that as a yearly didactic on the curriculum as well. So we'll revisit it again sometime in the coming year. The only announcement that I have is that our next session will be on March 7th, and Dr. Sharma will be discussing vaping-related lung injury. So keep an eye out for that reminder, and we'll see you all next time. Thank you.
Thank you.
Bye.
Bye-bye.